بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته جميعا. Tonight is 21st night of and week of Anaesthesia and Critical Care refresher course, Saving Lives Academy, and 2 lectures as usual. The first lecture will be with Professor, hopefully Professor soon, Dr. Ahmad Madi. So it's a good omen. Dr. Ahmad Madi is actually a clinical assistant professor in 2 universities. I know a little or very few people that's working as assistant professors in 2 universities. So King Saud, Al-Imam Muhammad ibn Saud University Hospitals in Riyadh, Saudi Arabia. And he's assistant professor of anesthesiology and intensive care as well in Tanta University Hospitals. His main interest is critical care. He's working as a critical care consultant for maybe 20 years or even more. So I trust Dr. Ahmad Madi tonight will talk to us and will take us through a journey from the Rivers Etal trial crossing by the 30 ml per kg sepsis campaign guidelines. We may end up discussing the Clover's trial that's recruiting patients still. So this is our ICU daily challenge with fluid resuscitation. When to start, how to stop, when to stop, how much fluids. Is there a standard of care in the fluid management, or is there a best technique? This is what we may explore tonight with Dr. Ahmad Madi. So Dr. Ahmad, please, can you start sharing your presentation and go ahead?
Sorry, I'm mute now. Yes. Assalamu alaikum, everyone. Thank you, Dr. Walid, so much for this very nice presentation and really a great effort to deliver this a course over 6 months. And weekly we have a session of from eminent speakers worldwide. And I'd like actually to thank all the faculty joining and sharing this event. Bismillah ar-Rahman ar-Rahim. Today we will have just insight or highlight about the patient in ICU. Common scenario, we have it in ICU, patient in sepsis or septic shock. Does he need fluids? Does he respond to the fluid or not? And I'd like to disclose that I retrieve a few slides from some figures worldwide, like John Tupoul, and actually I'd like to thank him. He gave me permission, and he gave me his slides since 2007. And Prof. Muhammad with us from Alexandria. At that time, he was presenter in ASAIC in 2007, and I met him for the first time, Prof. John Tupoul, and he's eminent, and he's one from the figure, as well as some slides from Mayatra, from the Baker, a few slides, and others are mine. We have to talk today about some sort about fluid responsiveness. Does my ICU patients need fluids or not? I'd like to share with you this case scenario. Let us start. If we have 55 years old male patient with history of cancer colon, and he has inferior MI with ejection fraction 40%, presented with intestinal obstruction. 4 liters of fluid was given in the ward before he would come to the ICU. Then he presented with tense, distended abdomen. Post-op. He's ventilated with high setting of mechanical ventilation, as you can see it here, FI2 70% with PEEP 15. Leukocytic count rising to 18,000. He has the highly fever, highly febrile, tachycardic, blood pressure 80/50 millimeter mercury, so he's hypotensive. He has central line, and they are measuring CVB. They found it 14 millimeter mercury. Measuring lactate, one from the most important item from the first hour condyle, found lactate is 6. So I receive answer before the question. So should we give this patient fluid or not? You have two answers, yes or no. Kindly share with me in the chat room. This patient, does he need fluid or he doesn't need fluid? Just I will give half a minute. I can see most of you going with no. Little going with yes. Oh, need fluids, no, no, no. I can guess. Okay, so the majority going with no. This patient doesn't need fluid. Let us analyze this patient. We said this patient, why yes? Why this patient, you will give him fluid? He has sepsis. He's relatively hypovolemic due to vasodilatation. He have, of course, sequestration of the fluid with third space also. He has persistent tachycardia as well as high lactate. So the one who's answered yes, he has his rationales. The one who's answering no, also he has his rationale. CVB is 14 millimeter mercury, is high. And he received already 4 liter, and his cardiac patient with ejection fraction 40%. So actually, this patient is a dilemma of giving fluid or not to give fluids. Right? If we will go back to the physiology, why we are giving fluids for our ICU patients, or for any patient, even post-operative? Usually, we have 4 indications. The first of one of them is nutritional. All of us agree that with this patient needs some sort of calories, and you can replace him if he's taking oral. He doesn't need to give any IV fluids in this stage. Or you need to replace the loss, maybe from GI loss, maybe from bleeding, maybe for whatever. And I can say in the future, maybe this is will be the only indication for abnormal saline, which is replacing chloride in patient who has GIT loss. Or a maintenance. Usually in anesthesia, you have a patient who's fasting, you have a patient who's NPO for longer time for any procedures, and you need to replace his fluid at the maintenance fluids. And the most important for us in ICU is the 4th indication, which is resuscitation. This is where we will focus on resuscitation of the patient, because this resuscitation is an acute stage of septic shock patient, and it has to save life. And most of the guidelines focusing on resuscitations, and any one of us giving fluids for this patient as a part of resuscitation, either for his absolute hypovolemia or relative hypovolemia due to vasodilatations. All of us agree that dehydration is bad, and the hypovolemia can affect tissue oxygenation and organ perfusion, and can even lead to death. As well as evidence-based worldwide, hypervolemia also is very bad and has many complications, increasing intra-abdominal pressure, lung edema, and healing of the wounds, many complications, and by evidence, it's many trials showing that increasing the mortality and increasing ICU length of stay. So I would like to start with the messages. The first message I'd like to tell you about it: consider fluids are drugs. You have to think about it like drugs. When you are giving any antibiotics or any antihypertensive medication, you are thinking 100 times. You are worried about the side effects, toxicity, overdose, underdose. So please, when you have the fluids, you have to have the same concept. When you give fluids for such patients, you have to have the same concept. And also, it's shown when you are controlling the fluids with fluid responsiveness guided, you have a favorable outcome from ICU, as we can see it in this study done in 2017. You can find goal-directed therapy guided by assessment of the fluid responsiveness appear to be associated with reduced mortality as well as length of stay and, of course, duration of mechanical ventilations. Many studies done to prove that. So, what does it mean of fluid responsiveness? Fluid responsiveness means when you give your patient the fluid, the heart will respond by increasing its stroke volume and hence cardiac output. To achieve this target from the fluid resuscitation, you have to have a proper system. You have to have pathways to have this achievement. First, you are relying on intravenous fluid to improve the expansion of the intravascular volume, which is increasing the stressed blood volume and consequently increasing the main systemic pressure without increasing the atrial pressure, because the venous return depends on the two pressure, forward and backward. And I will explain this one in the couple of the slides after this one. So to achieve the responsiveness of the fluid, you have to have a proper venous return, as well as you have to have a good cardiac function. The heart will respond well. He will eject stroke volume, which is increasing with the fluid you are giving. Without those pathways, you cannot achieve favorable outcome from the fluid you are giving. So let us have it in details. If we think about what targets from the fluids you are giving, all of us know we are giving the fluids for the shock patient, and we have end user. We have a cells at the end, the hypoperfusion for the cells. We want to improve organ function at the end. So think about it. If you look to the circulation, you are giving a fluid here in the venous side, if you can see it here. Assuming this fluid in the venous side will go to the right side of the heart and to the pulmonary circulation, coming back to the left side of the heart, and ejected by the cardiac contractility to have a good stroke volume. On the same time, you had good vascular tone on the arterial pressure, which is driving the fluids to the tissues. And assuming you have good microcirculation, as well as the diffusion of the oxygen to the cells. So long journey to achieve between fluid infusion and the organ function. So we need to have a response for the fluid. The response, it means you have giving fluid, you have increasing this station, these steps to achieve at the end the target. It means if you give fluid, main systemic pressure has to increase, cardiac output has to increase, MAP has to increase, microcirculation has to improve from the fluid you are giving to say my patient responder to the fluids I'm giving. Of course, many barriers to achieve this. You have vasodilatation, you have high CVB, you have poor cardiac contractility, you have microcirculation derangement, you have disruption of the glycocalyx, you have many, many barriers on the way. You have to think about all of this. So when I'm saying fluid responsiveness, I'm saying fluid infusion has to increase the main systemic pressure, which has to increase the cardiac output. And the third step, MAP. So if we think about responsiveness, you have to think about those effects by the fluids you are giving. Let us take it one by one. Does fluid infusion increasing my main systemic pressure? First, what is the main systemic pressure? If you look to the veins, looks like this balloon. When you have the balloon which is shrinked, unstressed volume inside this venous side, when you have this in venous capacitance increasing to this stage, this is called unstressed volume. Just take the shape, conformation of the venous side without exerting any pressure on the wall. All of this, we called it unstressed volume. It doesn't have a space apart, a rule in the venous return. What we have a rule in the venous return, the fluids after this stage, which is stressed volume, the volume exerting a pressure on the venous wall. This is the main systemic pressure. So if you are infusing a fluid in the venous side, you have to increase the main systemic pressure, which is a stressed volume. You have to increase it in the venous side. Not only that, if you increase the main systemic pressure, this is the forward pressure. We have another pressure high up here in the right atrium, which is the CVP, which is the right atrial pressure. If you have main systemic pressure here in the stressed volume, and if you have right atrial pressure here, so that the difference between them, this is controlling the venous return. Let us think about it. If you are increasing the main systemic pressure, on the same time, you are increasing the right atrial pressure, so no effect on the venous return. What do you achieve, want to achieve from the fluid? To increase the main systemic pressure without increasing the CVP, or at least no significant increasing, because if the CVP increasing more than the main systemic pressure, no venous return, it will be decreased, so you will not achieve the target. So if you think about it, you will know here the rule of central venous pressure, which is the main atrial pressure, which is the backward pressure of the venous return. For that, we did agree for the Starling curve, in the ascending portion of the curve, cardiac output can increase, right? But if this cardiac output increased, if it is associated with increasing in CVP, which is the black line here, so will not achieve responsiveness. Cardiac output will not increase. So what do we need? We need increasing the cardiac output without increasing in the CVP, or minimal increasing in CVP relative to the main systemic pressure. So we need to maintain the gradients, or at least increase this gradient between the main systemic pressure and the CVP. So I think with this view, you can know what is the rule of central venous pressure here. I cannot say the central venous pressure play a role in my patient responder or not. No, I cannot say that, because it doesn't have a rule for the responsiveness. And many articles coming to tell us central venous pressure doesn't have a rule for venous fluid responsiveness. But you can use it as a safety margin. You can use it as alarming point. Central venous pressure, yes. If it starts to increase, so you are expecting the gradient will be decreased, so no venous return. So not responded, the patient will be not responder. So central venous pressure is not abundant anymore, and it is not useful anymore. So you have to know its rule in the patient assessment of the patient with the fluid responsiveness. Many assessment tools to tell you about my patient will respond to the fluid or not, either dynamic or static. Of course, static it is less reliable. Dynamic is more reliable than static responsiveness, which is change in the parameters you are measuring. So if you have static parameters like central venous pressure, like wedging pressure, like global end-diastolic volume, like flow time corrected by the cardiac, whatever the machine giving you, any static measurement, it is not a good tool to assess the response of the fluid, responsiveness of the fluid, but it can use as alarming limits. If it's increasing, you have some sort of alarm, you have to stop. What we are relying on now, the dynamic parameters. All of us hear about everything about them, either using systolic pressure, or pulse pressure, or stroke volume variation, or a change in the inferior vena cava or superior vena cava, or a changing in the velocity of the aortic, or a delta aortic blood flow, or even using the superior vena cava or other parameters, or seismograph, many parameters for dynamic measurements. All of them relying on you are giving a fluid, challenging of the fluid, and if the patient will be responder, he will be here in the ascending part of the Frank-Starling curve, and you have a change between inspiration and expiration, whatever the parameter you are measuring, stroke volume or pulse pressure or systolic pressure variation, or whatever you are measuring, right? If the patient in the flat portion of the Frank-Starling curve, and I can tell you, everyone have its own curve. Not only that, it differs with the stage of the shock stage. You can have the patient in this stage earlier, but when he starts to have cardiomyopathy, when he has cardiac contractility poor, the curve can go down. So it is a dynamic state. So you need to assess the parameters with intervention you are giving. So we have intervention, which is cyclic change. Of the respiratory cyclic change, we have venous return change, preload will increase, and I'm assuming I have a response from the heart. As we have mentioned earlier, the stage before the heart, which is the central venous pressure and the main systemic pressure, now we are focusing on the cardiac output, stroke volume, increasing or decreasing, as well as the pulse pressure. Why cyclic change in the respiratory cycle during mechanical ventilation making this change? Because as all of us know, mechanical ventilation increasing in intrathoracic pressure, but don't forget as well increasing also intra-abdominal pressure, right? So we have dynamic change in the lung volume. If you have a patient which is volume loaded patient, normal patient, both of them will change intrathoracic pressure as well as intra-abdominal pressure, but pressure gradient maintained. So this patient, they have good venous return, it's constant. But for volume depleted patient, we have collapsing veins. We have narrowing of the veins. So even we have increasing intrathoracic as well as intra-abdominal pressure, but the venous return will be decreased in volume depleted patient. This is a cyclic change with the mechanical ventilations. Evidence-based, many showing change in the evidence-based was cut off of 13% between the responder and non-responder with pulse pressure variation, with stroke volume variation. I can say we have a gray zone between 7 and 13. You can tell me above 13, the patient will be responder. Less than 7, the patient will be not responder. He doesn't need fluid. With high sensitivity and specificity, many studies, I can say more than 300 articles to tell me your patient dynamic change, like stroke volume variation, as you can see it here, pulse pressure variation, as you can see it here, most of them by the figures of the hemodynamics worldwide. Of course, it is better than static parameters like wedging pressure or cardiac index or CVP, right? With high specificity and high sensitivity. With cutoff 13 for both of them, as I say, we have a gray zone between 13 and 7. If you look to the articles, hundreds of articles talking about the responsiveness of the fluids, does it valid or not, with the cyclic, with the mechanical ventilation changes. Yes, it shows good accuracy and validity for the patient and good assessment for the responsiveness of the patients. Of course, another, let us say, track of ultrasound and echo, and I will keep it for our pioneers, Dr. Aid and Dr. Ashraf Tayyar. Actually, they have a very good, of course, experience in such. Also, the same concept. We have the intervention and we have parameters to measure, right? Whatever cyclic change of the mechanical ventilation can affect the velocity of the aortic, and as well as the time integral, as well as the distensibility or collapsibility of the inferior and superior vena cava, with, of course, certain limitations. Another important message: your patient coming to the ICU mostly late, not in the early stage, with the very common meta-analysis done by Xavier Monet and John Tipoul, 50% only of your patient will be responder in the ICU. So kindly don't make it as a standard of care in the ICU. Unlikely most of the patient will not be responder. And another study done by Silverside 2019 to show when your patient will be responder, as you can see it here, this blue color, over 400 patients, septic shock patient, this blue color, the patient will respond to the fluid management. And the early stage of sepsis, 57% responder. With time increasing, will not be responder. Again, I'm talking about resuscitation of the fluid, right? So please think 100 times. Check your patient will respond to the fluid or not before you will give him fluids, right? And whatever the parameters you are measured, all of them are accepted. Every test has its own setting to be used in either in hemodynamical unstable patient in ICU, post-operative patient, OR patient in the ward or in ER. Everyone has its own test to be done with the complexity of the technology of the test. But the second important message here, the limitation of each one of them is before you will use the tool for the patient to give him fluid, you have to know its limitation, because really it is less specific and less sensitive in these scenarios. If you have the patient with spontaneous breathing, if you have the patient with rapid AF, or have intra-abdominal pressure is high, or right heart failure, all of them can give you false positive for those patients. As well as most common our ICU patients have ARDS. They have stiff lung, they have low lung compliance, as well as low tidal volume, or patient in open chest, and very high respiratory as well as heart rate. Those the limitations. So what is the solution? What we can do for those patients? We need just to change the intervention, because all of these limitations relying on the inaccuracy of the mechanical ventilation to give fluids. I cannot rely on mechanical cyclic change of the mechanical ventilation as a preloaded challenge for such cases. So what I need to do, I have to think about another intervention to do. Like I can just hold the expiration at the end to call it end expiratory occlusion test. Or I can do one from the very interesting and accurate test, passive leg raising test. or I can infuse some sort of the fluids, or I can change the tidal volume for the patient in ARDS from 6 to 8. And I can measure again what parameters, what the response, whatever, pulse pressure, stroke volume, systolic pressure. So the parameters I'm measuring, it is the same, but what I'm changing, the intervention, right? And I can actually say here, I will acknowledge the Prof. Sheila from Montpellier, and she's working in France with the Vermoni and Gentpool. She's the first author of the tidal volume challenging. She posted this protocol in this conference. All of us know about it since 2017 for the patient with ARDS. The patient was 6 ml per kg. She just increased it for a minute to be 8 ml per kg tidal volume, then going back again to 6 ml per kg and giving fluid bolus and checking the effect of increasing tidal volume for such patient to have a good heart-lung interaction with 8 ml per kg. Of course, the results was very, very favorable. Look at that. The left side of the figure, we have it here, the pulse pressure variation on 6 ml per kg. Of course, with 8 ml per kg, as you can see it here, more sensitive and more specific, as well as also the stroke volume variation at 6 ml per kg, as well as the stroke volume variation on 8. Not only that, she have noticed another important one, which is the difference, the delta pulse pressure change and the delta stroke volume variation change. The delta pulse pressure change here from 6 to 8, more than 0.3%, 3.5%, shows more sensitivity and more specificity closing to 100%, as well as stroke volume variation from 6 to 8. The delta change in stroke volume variation have more sensitivity and specificity rather than even the stroke volume of 8. So she's playing with the volume, with the tidal volume, to have a good effect and good reliability for the responsiveness, fluid responsiveness for such case. Another important test we have mentioned just in expiratory occlusion test. The scenario, we have the normal one. During cycling in shade of mechanical ventilation, venous return will increase. Cycling decrease in the preload with the expiration. So if you just hold it during expiration for 15 seconds, you need to measure the cardiac output. During that, the change in the cardiac output more than 5%, this patient consider him responsiveness for the fluid. Those for the patient have limitation for the standard fluid responsiveness test. So in the expiratory occlusion test, and shows actually 90 sensitivity with a 100% specificity for such case. Another amazing test, which is very easy to be done. Another way of the internally challenging for the preload, autologous transfusion of the blood of 300 to 500 ml of blood. Just raise his leg in this position, going up to this position, and check the responsiveness of that. This is the same fluid challenging, but autologous, internal transfusions. But the beauty of that, we are not giving fluids from the patient himself, as well as this effect is reversible. You can take it out and the transient. So very good test, and hundreds of articles showing the passive leg raising test in the limitation of the standard fluid responsiveness test was cut off 10% of the cardiac output, have a very good sensitivity and specificity to tell my patient cardiac output will increase with the fluid challenging for such case. So passive leg raising test, you can say many trials coming. Of course, this one by Vermoni and Gentpool in 2008. They published it. Since that time, the validity of the passive leg raising test and easy to be used in ER and ICU to check your patient, he will respond to the fluid or not. And a very nice article came to tell us for the passive leg raising test, also published in 2015 in Critical Care Medicine, also by Vermoni. He's the senior of this study. Rather than, I do like the color of the column. Let us look at it. They measure the gradient between the main systemic pressure as well as the CVB here. They did found with the passive leg raising test, they did found it significantly increase in this gradient for the fluid responder. So what does it mean? It means passive leg raising test significantly increase the gradient between the main systemic pressure with the CVB. So those patients means responder. As we remember, the first step of the volume expansion is the venous return, which is affected by this gradient. The second step of the fluid responder is the cardiac contractility, or the response of the heart, which is the Frank-Starling curve. The non-responder patient doesn't have increase in this gradient, as you can see it here. Right? So if we look from the outside for the fluid we are giving to a patient, in the venous side, we have now two very important forces to think about it: the gradient as well as the stroke volume. So I have a question here. Let us say my cardiac output increased. I gave a fluid for my patient. I did a fluid response, in this case positive, and cardiac output increased. Are you sure that increasing the cardiac output can augment the blood pressure, can increase the MAP? If you are agree, just say yes. If you are not agree, just say no. Please, you can reply in the chat. No, yes, no. Yes, no. Look like equal. Half yes, half no. I don't have gray zone. I don't have in between, either yes or no. Of course, if I would say maybe would be the right answer. Okay, that's enough. Let us see. A very nice study done in 2019, published last year, actually, right? Which telling us, this is the left curve here, showing the Frank-Starling curve. Those patients prelude increased, cardiac output increased. But this right curve showing the relation between the cardiac output and the arterial pressure. If you have the patient with low vascular tone, blood pressure will not improve. You need to have good vascular tone for your patient to augment his MAP, his cardiac, his arterial pressure. So it means my patient, when I'm giving him fluids, it's not as easy as it is. We need to have a gradient between the main systemic pressure and the venous return. We need to have a good cardiac contractility to augment the cardiac output. We need to have a good vascular tone to increase the main arterial pressure. For that, nowadays, they think to start, not to start, which is first, catecholamines, vasopressors, or fluids. Many studies going now to tell us early vasopressors, I think, will be better than that fluids management. Okay. I have the last question in this lecture. Let us have it. This is the last question. I'd like your opinion. Fluid responsiveness equates to the need for fluid policies. Again, my patient, he responder. This is equal. He needs fluids. Let us look to the chat. Agree, not agree. Not agree, agree, not agree, agree. Looks like most of you agree. Oh, no, not most. Walid, I think most of them agree, right?
Correct.
All of them won. Don't. Good. Okay, let me ask you a question. If I do fluid responsiveness for you, you will respond or not? All of us will respond. All of us will be responders for the fluids. I will share with you one from the most important message I want to tell you. As well as, if you have the patient who needs fluids, over, clear, this patient needs fluids. The patient early in sepsis, he needs fluids. The patient is in hemorrhagic shock, he needs fluids. So don't go beyond giving fluids. Don't assess his fluid responsiveness, right? So this normal patient, this is clearly he needs fluids, right? But we are dealing with the patient who may or maybe not. In such case, please remember this message. We are giving fluids for the patient who have acute circulatory failure, number 1, who have showing the responsiveness for the fluid, number 2, and at the end, which is the very, very important, he doesn't have risk for giving the fluids. You are weighing the risk and the benefit. He may benefit from the fluids, apparently, as you can see in the fluid responsiveness test, but it can harm him from another way. So please remember those 3 messages for the patients. You give him fluids, acute circulatory failure, fluid responder, as well as no risk. Many questions coming in clinical scenario when I'm going to the patient in ICU. I have a patient in ICU, his blood pressure variation is 20, he needs fluids, I have to give him fluids. On the same time, he's bubbling, his lung is edematous, he have pulmonary edema, he have a risk. Those patients don't give them fluids. And it's clearly mentioned here, when you have 2 graphs together, Merrick curve for the extravascular lung water here and the Frank-Starling curve. Look to these 2 curves. Here, this patient responder with the fluid, yes, because he have large increase in the stroke volume here, as you can see it here. When you give him preload, large increase in stroke volume. Because those patients have gradients, still have the gradient between the main systemic pressure and CVP. Those patients have small increase in the extravascular lung water when you look to their curve, their curve here, small increase in extravascular lung water. If you look to another patient here, it can be responder. We have a small increase in stroke volume here, but we lost the gradient. CVP increased, main systemic pressure increased, but the gradient lost, decreased. Those patients on the same time showing large increase in the extravascular lung water. So when you combine those curves, giving you the message, please, even if your patient is responder, you have to think about the third, there is no risk. Extravascular lung water, one from the very, very good tool, assist for the patient who have overloaded of the fluid and sensitive, and showing us with the 50% and more, higher 50%, with the 20% and more, 50% of the patients will die. So fluid responsiveness in a reasoned way, simply check assessment condition, check limitations factor. If you don't have any one of the limitations factor, just go with the dynamic indices, the standard one, pulse pressure variation, stroke volume variation. If they showing positivity, give fluids. If they are in the gray zone between 8 and 13 or 9 and 13, or if you have a limitations for those, you have to think for another alternative fluid response, another intervention to assess the fluid responsiveness, which you have just mentioned now, either tidal volume challenging, fluid bolus challenging, passive leg raising test, and the expiratory occlusion test. Those patients, if showing positivity, those they need fluid, but there is no risk, there is no harm of giving them a fluids, because those usually assessed late when they start to have lung edema. So consider those patients without risk of the pulmonary edema or whatever. If no, think about another way like vasopressors, like inotropes for such patients. Okay, another benefit from the fluid responsiveness, which I'm feeling more important than giving the fluids. Yes, when you're taking the fluid out, you need to check fluid responsiveness. Those patients, not responder, don't get fluid. Stop fluids. Not only that, when you are giving fluid out, just take a look on hemodynamics. Again, central venous pressure. When you're taking the fluid out, you are decreasing the mean systemic pressure. You are taking the intravascular volume out. On the same time, you have to decrease the right atrial pressure here. So you are maintaining the gradient. So you are maintaining the stroke volume. Once the stress volume decreased, without decreased in the central venous pressure, stroke volume will decrease. So when you're taking fluid out by ultrafiltrations, you have to monitor the patient hemodynamically to tell you, please stop. Stroke volume start to impair. Central venous backward, the pressure start to still higher than that the intravascular pressure. So you can use them. If we now understood the venous side as well as the cardiac output as well as the vascular resistance or the manual arterial pressures, are we guarantee the patient will respond and organ function will improve? We still have another big, let us say, place or stage, which is the microcirculation, which I'm believing still not yet in well practice, in clinical practice, but it has to be. Because when you are augmenting the blood pressure by the fluid you are giving at the beginning, you are relying on two factors for delivering oxygen to the cells. The convective pressure here in the microcirculation, as well as the diffusion of the oxygen here, which is called diffusion distance. This is at the level of the microcirculation, right? So if whose patient will respond for the fluid at the level of the microcirculation, the patient will increase his convective microvascular flow. On the same time, don't think the edema on the extracellular fluid here, it is cosmetic only. No, look at this one. The diffusion distance will increase if you have edema in the tissues. Oxygen delivery will decrease. So edema is not cosmetic. It is affecting the delivery of the oxygen. So at the level of the microcirculation, I think we need to have also microcirculatory responsiveness tests on the level of the convective flow on the microcirculation, as well as diffusion capacity or diffusion distance of the oxygen on the level, which is not yet well in clinical practice, but we have it. So who will respond to the fluid? Who will get benefit from the fluids? As you can see it here, he has to have preload responsiveness patients, good cardiac contractility to increase the stroke volume, optimizing of the cardiac after load. This is for the macrocirculation optimization to improve, to have the effect of the fluid on the microcirculations. I have something here just to add because I just read it about the new technology which is added in the intraoperative. Personally, I didn't use it yet, but I read about it. They have some sort of prediction whose patient will have hypotension after 10 or 15 minutes. They have an analysis of the high technology of the arterial pressure waveform using contractility effect, aortic complier, systolic phase, diachrotic notch, everything to show us what is called hypoprediction index. Look at here, intraoperative studies, they show blood pressure here on this curve and prediction index of hypotension here. When they found hypotension prediction index more than 90% increasing, so those patients after 15 minutes here, they will develop hypotension. So it's a very good prediction to tell you your patient will be hypotension after 10 to 15 minutes. How it looks like in the screen, you have the curve of hypotensive prediction index. And when you have this curve, the curve will give you alarm. Take care. Your patient after 15 minutes or after 10 minutes, he will have hypotension. And it will give you another screen. Maybe due to preload, check. Maybe due to contractility, which you have another assessment for contractility. Maybe which is another effect of the afterload. So you have to think about those patients, why they can develop as a prediction for the hypotension, mainly intraoperative. Published in Anaesthesia and Analgesia, and you can see it here, hypotension prediction index with timing 15 minutes still have the sensitivity and specificity of 80%. Look at here, those with timing. Of course, earlier, more sensitivity, later 15 less sensitivity. But at least it can tell you at an assistant side or your patient can be hypotensive after some time, after a few minutes. I'd like to conclude with 4 messages. First one, assess fluid responsiveness using dynamic indices. Second, even if your patient is responsiveness, just remember, we are giving a fluid for the patient who have acute circulatory failure, who doesn't have no harm from the fluid. There is no risk of the fluid management. passive leg raising test can be used in situations where the heart-lung interactions are unreliable. No test is perfect. You have to integrate. It is a puzzle. You have to integrate together to reach with your clinical assessment. It is very essential to reach to the final diagnosis of your patient who responded or not. Thank you so much. And I'm willing for the question.
Perfect. That's very good, Dr. Ahmed. Thanks. As usual, very comprehensive pathophysiological principles, technicality, and modes of resuscitation here. Allow me to stop your PowerPoint presentation. Good. So we have a couple of questions here. We'll start with them. How can we suppose to take central venous pressure or right ventricular pressure just as an alarming parameter, while it is a main component of venous flow during the pressure?
Central venous pressure, generally, right? It is not a test for fluid responsiveness, but I can say if you have a low central venous pressure, yes, you can use it to give some fluids. Some literature giving some sort of even central venous pressure variation to give some fluids. This is in basics of the ICU, right? But when you have little bit higher, please, you have to think, you have to stop. The limitation usually coming with higher CVP, so don't rely on, right? And central venous pressure, I will not take it out because all perfusion pressure relying on central venous pressure, right? So I hope you can use it if you have low figures, but when you have higher figures, don't rely on it.
Perfect. So I may still add one note here, Dr. Ahmed, if you allow me. I had seen some patients with aggressive fluid resuscitation, 10 or 11 liters, and they became anuric. The abdominal pressure is very high, so they have IVC diameter and indices in the very low state. And depending on that, whoever was at bedside with IVC diameter and index, suppose giving an IVC of less than 10 or less than 5 centimeters, because no central line at this moment yet. Patient was in ED, didn't have a central line, so they kept giving more fluids and more fluids while the patient has a compartment syndrome. So the message here is like, take care of strange scenarios that may come in, or don't be confused with when the CVP is really low or there's something that's causing a false low CVP. That's why we don't trust CVP. Do you agree with that?
Yes, sure, because actually, if you again going to the physiology with the guide of care, you can find the area of, we called it waterfall area. In this area, you can find the IVC even collapse it, right? But you cannot rely on, you cannot say this patient will need fluids, right? Because automatically with high intra-abdominal pressure, the fluid can go without. So this is, don't rely with high intra-abdominal pressure with such case. Again, it is in the context of puzzles. You have to think about it. Those patients, I'm agreeing with you. You have to think about. Personally, I'm not relying in CVB for any management of the fluid for any patients.
Perfect. And on the contrary side, another confounding factor, when you have a patient of ARDS or high PEEP or high mechanical ventilation setting, or even with a pulmonary embolism.
Yes.
So
right
you still,
yes.
Yeah, you may still give fluids to augment right ventricular output in these scenarios. So patient will have a CVP of 20 and we're still giving fluids. So CVP is actually not reliable at all for fluid resuscitation. Particularly, I always say we are judging the right ventricular pressure to judge a left ventricular end diastolic volume. It's a long journey from right atrium to the right ventricle to the lung or the pulmonary circulation, back to the LA and LV. Actually, you are judging the LV pressures, and with grade 1 diastolic dysfunction, you lost the correlation of pressure volume relationship between left ventricular pressure and volume. So this is the very first relationship you have at the level of left ventricle. Imagine the reflection on that on the right side after all this long journey. So CVP is nothing, if you agree with me.
Yes, and actually, I here appreciate so much the ultrasound and the echo because it can give you the full picture of the pulmonary, of the right side, of the collapsibility, everything. So I really appreciate here the echo and the ultrasound to be used in this scenario, which is a common scenarios, which is almost misleading, right? Because most of the ARDS patients have right ventricular dysfunction. They have whatever diastolic, as Walid said. You have pulmonary embolism. So all of them misleading if you are relying on the central venous pressure as a measurement, either even to get fluid or even to assess the right side of the heart.
Perfect. And here comes actually, Dr. Ahmed, the second question, which what is the easiest reliable way to check the microcirculation, the micro circulation, not the macro circulation? Do you think echo bedside to measure cardiac output by echo is enough? A question by Dr. Ahmed Kuhil.
For microcirculation?
Yes.
No, microcirculation actually it is another big place or field. We need to think about it. For microcirculations, you have two steps. First one, the microvessel itself. The second one, it is the cell function itself, right?
Mm-hmm.
Let us say microvessel itself, we can rely on some sort of tissue oxygen saturations, which is still even like near infrared spectroscopy. But the most important one, which is the cytocam imaging of the microcirculations, which is well developing. Ken H and the Becker, the figures of those now, and they are very excellent. Not yet in practice, sublingual camera or cytocam. This is the most important one for microcirculation. But we can rely on the third part, which is the cells itself, the biomarkers. Go to the biomarker to assess you the perfusion there. You can rely on the lactate, you can rely on the carbon dioxide gap, you can rely on the mottling, you can rely on the another biomarkers you can rely on for the microcirculation.
So during the third question coming here, Dr. Ahmed, allow me to document the attendance. So please feel free to remove this pulse screen from in front of your self. So a question from Wala Al-Ali. In cases of IVC mass or a thrombus, what will be your fluid management strategy? And what about the pulmonary embolism cases? So I think we went quickly through this one, but it's a bit, it needs actually to be answered.
And it's a very hard scenario to have the patient with IVC mass, but of course we will not rely on the intravascular assessment of the CVP or whatever. You need to assess the pathology, how it's compression, and the pulmonary embolism. Also, the very important. And I will tell you my clinical part. I'm not going with the fluids with the pulmonary embolism as aggressive as any patient of septic shock patient because you have right out ventricular flow obstructions. So you need, if you are increasing your fluid, you are almost worsening the right side. You are compromising the left side. So I'm not going aggressive with the patient with pulmonary embolism. For intraventricular mass, of course, intravascular pressure are not relying on. You need to have assessment of the cardiac function. You need to be with the fluid challenging and assess how the fluid response from the other side for the cardiac output. But will not rely on the central venous pressure or any pressure while you have mass inside the intravascular inferior
vena. Can I summarize, Dr. Ahmed, and correct me if I'm wrong? Fluid resuscitation starts from the history taking. So if the patient is septic for the last 4 or 5 days and he is NPO because of sepsis, I'm expecting this patient at least to get 2-3 liters of fluids before we need the vasopressors or we kick in with the vasopressors. Then examination, examine the patient well. Is there any lower limb edema, pulmonary edema, any murmurs on the heart to say there is an aortic stenosis or mitral insufficiency? Clinical examination is very important as well. See the jugular venous pressure. Then after you examine the patient, start use the investigations like lactate and perfusion parameter, central venous saturation, and then use the simple aids of ultrasound and echo to add the last piece of the puzzle. And you can use passive leg raise test, dynamic parameters, but I think it's all together. It's never a one box to be ticked, and this is the best thing for all patients. No plan fits all. If you agree with me or you have any other proposal.
I can say Walid is minded by the European Society hemodynamic modules. What he's mentioning now, it is exactly present in the hemodynamic module. You have initial assessment for the patient and you have advanced assessment. the initial assessment in hemodynamic module of the iliac. The first one, of course, medical examination, assessment, GVB, cardiac, ECG, even history, lactate. And the third step, you have to go with fluid responsiveness, as of course, fluid responsiveness now in all guidelines of septic shock patients. And the advanced technique, you have to go with the more advanced technique. So this is the let us say stepwise, or the flow chart to assess your patient in hemodynamic way, right? But I just want to remind you that the septic shock patient, you have to check. Usually, when he coming to, the timing is very, very important for septic shock patients. He's coming from ER, he's coming from another hospital, he's coming from home, and he's landed in ICU. Usually, they did find that fluid microcirculation responsiveness for septic shock patients, it doesn't happen after 24 hours to 48 hours. Nothing to be done with the resuscitation after 24 to 48 hours with septic shock patient with microcirculation. So those patients resuscitation as early as you can. As I mentioned the earlier, responsiveness will be with delayed time. The patient will need to be responder. So timing is very essential to assess him. For that, I think, I don't know you have it in Europe or that, Walid. There's some, I heard about it. There's some like smart code or code sepsis code team, which is announcing like code blue for septic shock patient with some of the scores, which is very likely to assess the patient in sepsis. They announce it for the smart code or the sepsis code team. They are going very fast with the fluids, with the antibiotics, with everything to manage the patient as life-threatening, as emergency, as early as they can for the fluid, for the antibiotics, for whatever the septic shock bundle or the sepsis campaign bundle. Because, of course, all of you know, one from the highest mortality reason for the worldwide with the sepsis, and they are fighting, and it's preventable. So they are fighting it as early as they can. I'm agree with the stepwise approach for the hemodynamics.
Perfect. So I think we are finishing here the first lecture. My full appreciation and thanks to Dr. Ahmad Madi for his wonderful and fantastic presentation tonight. And we'll go ahead straight forward to the second lecture. It's about the chest trauma, blunt or penetrating chest trauma, with a main focus on the management of rib fractures by Dr. Mahmoud Al-Khulani. Dr. Mahmoud Al-Khulani is currently in his last month is doing a senior reg for pain medicine and anesthesia in the national training program at the Manchester University Hospitals. And he's starting soon, I think maybe in 1 or 2 months max, as a consultant job in the same hospitals. So Dr. Mahmoud's special interest is medical education, and is appointed actually as an honorary lecturer in the Manchester University since 2017. So he's doing that job for the last 3 years. So this topic of blunt and penetrating chest trauma with a focus on rib fractures carries a very importance or clinical importance, as it carries a significant mortality and morbidity, particularly in the elderly people. Carries a lot of challenges like pain management, ventilation support, which is again related to the pain management. And as you know, the scoring systems may not be reflecting reliably or predicting the failure of your conservative measures and treatment. So Dr. Mahmoud, please start sharing your presentation and go ahead.
Right, thank you, Walid, very much. A very good evening to all the audience attending tonight. I hope all of you guys are staying safe and sound during the second wave of COVID-19, which is knocking around, unfortunately, now in the very surreal, bizarre year of 2020 that keeps surprising us. Last thing today with, fortunately and luckily, Donald Trump losing the elections in the United States. Not that the other candidate is going to be of any benefit to our Middle Eastern interests, but it's just an end of an era that needed to end, really. First of all, I'm really glad to be with you guys here tonight through the splendid portal of Saving Lives Academy and my very good friend, Dr. Walid Al-Habshi. All greetings as well to the panelists, and all greetings to Dr. Ahmad Madi. And thank you very much, really, for his very interesting lecture tonight. So like Walid said, there is a little bit of tweak in the topic. So the announcement was I'm going to talk about blunt and penetrating chest injury. But to be perfectly honest with you, I always try to focus on areas where we can actually achieve some improvement in the quality of care, if I can say that, where there is potentials for improvement. And one of these major areas, actually, when we are talking about chest wall trauma, is the management of rib fractures. The bigger picture is more of surgical emergency medicine problem. Yes, we are involved in it, but we are more closely involved with the management of rib fractures. And this is why tonight I wanted to focus on this more rather than talking about the wider picture, which has more input from our colleagues in surgery and emergency medicine. So let's delve in our topic today. So first of all, conflicts of interest. I have none to declare here talking about this topic. My objectives tonight talking about this important topic is to shed light on the relevance of rib fractures. Why do we think it's an important area of practice that we need to improve and focus on? And then we'll talk a little bit about how to approach a referred patient with rib fractures, how to assess those patients, if there are any scoring systems in place that might aid us, and how reliable those scoring systems are. And then talking a little bit about management, specifically about analgesia, which makes a huge difference in the outcome of those patients. And then again, shedding a little bit of light of how to develop a governance system in place to monitor what we do with those patients and the outcome that we might have. So first of all, why rib fracture topic is really important. And numbers tell us that at least 1 in every 5 trauma patients will present with some sort of rib fracture of some description. Unfortunately, this condition comes with high morbidity and mortality for obvious reasons that we are all aware about. So you have patients with rib fractures, they are struggling to deep breathe and cough, and they end up having desaturation, needing ventilatory support, maybe developing some sort of pneumonia. And then this leads directly to mortality. And this has direct impact on healthcare systems. All healthcare systems nowadays are thinking money, how to save money, and that will never happen without improving the quality of care to our patients. So if this cohort of patient is not managed appropriately, unfortunately, you're talking about lengthy hospital stay, need for critical care, and now we are talking COVID and COVID era where ICU beds are really precious. So managing them appropriately from the outset helps to minimize all the burden on the healthcare system. Chest injuries per se account for up to 25% of deaths related to trauma. Even if you have survivors from this condition, they will carry on struggling with chronic pain conditions, need for long-term rehabilitation, and delayed return to productivity and work. And talking about Europe and talking about UK, with elderly aging population, this even becomes worse when you're faced with elderly frail patients coming with rib fractures and then developing respiratory failure, and you're in very difficult situation, needing to make decisions whether it's appropriate to intubate and ventilate those patients because of their rib fractures and the knock-on effects of such problem, or you just will palliate and keep them comfortable and not escalate their care. How do we fracture ribs? The most common is blunt chest trauma. In youngsters, as we would expect, the most common cause is having high impact injury, secondary to road traffic accident. While when we talk about the elderly group of patients, this happens more because of trivial injury, most probably losing balance and falling from standing height and banging their chest against something and fracturing a few ribs. And we see this quite often in our practice. There are other definitely less common causes like penetrating trauma, like knife injury, for example, and the knife crime here in UK is not uncommon, unfortunately. Maybe compared to North America, United States, they have more of gunshots. Here we have more of knife injury because they acquiring or keeping a firearm is something not common or legal here in UK, luckily. This might be stress fractures secondary to coughing, or you can see it in athletes, and other less common reasons One of them is quite interesting, actually, which is in pediatric patients. And this should directly raise your suspicion about non-accidental injury and what it will bring about in terms of safeguarding, etc. Just a little bit of anatomy that we are all aware about, just to refresh our minds about where the ribs are situated in our thoracic cage and what to expect. So we know that they are paired structures. The first 7 of them, we call them true ribs because they articulate anteriorly with the costal cartilage and posteriorly with the transverse process of the dorsal vertebrae. While the lower ones, 8 to 12, they are called false because they don't have anterior articulation. And from 10 to 12, they are called floating ribs because the movement and excursion is higher compared to the other ribs. The underneath of the ribs has the neurovascular bundle running in a groove, and this includes the intercostal nerves and vessels as well, which can get injured, unfortunately, during fracture, leading to bleeding and hemothorax or long-term neuropathic pain conditions after the healing process. One of the very important things that are actually very important indicators when talking about rib fractures is the term of flail segment, which can be diagnosed radiologically and clinically. And necessarily you won't have correlation between both because you can have clinical flail chest when it's not evident radiologically and vice versa. So you have actually to combine both assessments in order to judge a flail segment. And the significance of that, like what we're going to see later in the scoring systems, is it leads to high mortality because it leads to inefficient ventilation, where clinically you will find the chest wall, the segment that's broken, moving paradoxically. So during inspiration, instead of moving out, it will be sucked in and impair ventilation. And during expiration, it will move the other way around and impair proper emptying of the lungs and compromise ventilation. While radiologically, actually, when you see 3 consecutive ribs broken at 2 or more sites, this raises your suspicion about the risk of having a flail segment, and you have to search for this clinically to prove or disprove, and then plan your management consequently. Especially flail segment, like what we'll say later, is one of the most evidence-based indications for surgical fixation of fractured ribs. What are the consequences then? As what we all will appreciate, there is direct impact on ventilation. You're having a patient in terrible pain, maybe elderly with limited physiologic reserve. They are not able to deep breathe. They are not able to cough and get rid of secretions, and they are doing rapid shallow breathing. So this is going to affect their oxygenation and ventilation. And they might need varying degrees of support with supplemental oxygen, including non-invasive or even invasive ventilation. They might end up developing pneumonia, and this carries actually a high mortality risk, especially in elderly patients, leading to doubling of their mortality. Underlying the rib fractures, invariably you will find some sort of lung contusion, which might not be evident initially on your chest X-ray, but they will be evident on the CT scan, and those as well carry the risk of developing infection. And their natural course is spontaneous resolution if things don't complicate. You might get injuries because of the sharp ribs that are broken to the lung, to the pleura, and to the neurovascular bundle, leading to development of hemothorax or pneumothorax, or both of them. That's definitely in addition to the bigger picture. You're having a major trauma patient, and they might have different sorts of other injuries, including traumatic brain injury or injury to internal organs as well. And we're going to shed light on that while we are talking about assessment. When you come across those patients, there are some indicators that will tell you that that's a severe injury. One of them, like we mentioned, is having a flail segment, as well as having fracture of the sternum, which tells you that this is a high impact injury. Scapular fracture as well would raise suspicion about severity of this trauma. And if you have dislocation of the sternoclavicular joint. If you come across multiple displaced fractures, this tells you as well that that's a severe injury, or fractures higher up in the first 3 ribs, which are naturally protected by the scapulae and where the sternum is situated. And whenever you have these, you have to be very careful with your patient, because you might find more serious injury like myocardial contusion, dissection of the aorta, or dissection of the tubes running in the chest, including tracheobronchial tree or the esophagus. And you have to have, as early as possible, trauma CT scan for this patient in order to be able to pick up any injuries of worry that need addressing as soon as possible. Also, in that group of patients, there are high-risk protectors. And like what we're going to see later, they have been used in order to develop the scoring systems. One of the very important factors is age of the patient. The older the patient presenting with rib fracture, the more risk of mortality and morbidity. Again, as you would expect, intuitively, any comorbidities, especially relating to the cardiovascular or respiratory system, increase the mortality and morbidity risk of that group of patients. And again, number of broken ribs. And if the patient presents or develops early in the course of the problem, any pneumonic process, that will increase the risk of mortality and morbidity. So now you've been on let's say night shift, for example, and the A&E, the emergency department, calls you to assess a rib fracture patient as the anesthetist on call, who's skilled in at least managing the acute pain conditions, if not chronic, if you're like myself with interest in chronic pain medicine. How are you going to assess those patients? So here in UK, the usual practice is to get a CT scan trauma series from the outset as soon as possible, ideally within the first 30 minutes, and that's audited actually during the practice in order to see the extent of the injury and if that's associated with any injuries, which will guide our management. And that's done if the patient is not hemodynamically severely unstable, at which stage you might do a fast scan and then take them to theater if there is any reason to take them to theater immediately. In the assessment, clinical judgment actually is the cornerstone. Yes, we're going to talk about scoring systems, but your clinical judgment is the cornerstone. You go and you assess the patient. You try to see whether they are able to do deep breathing and coughing or not, whether they are able to use incentive spirometry and how much they are achieving. Normally, we look around 2 liters as a reassuring number, but if they are struggling and not able to achieve more than that, you need to act promptly and make sure that you're on the top of their pain in order not to have complications, and flag them to different teams like what we are going to say later, because it's not a one-man show. It's not only your responsibility as an anesthetist in your position, it's a multidisciplinary management that includes different teams having very important input in the care of those patients. Like we said, definitely if it's a severe trauma, you have to search for other injuries. You have to know whether there is a pneumothorax and whether it's a pneumothorax that will undergo conservative management because it follows the criteria of conservative management, or the patient will need an insertion of a chest drain, which is usually done here in UK by our surgical or thoracic surgery colleagues in A&E or the trauma team leader in A&E. Like we said, during practice, varying types of scoring systems have been developed. To be honest, none of them is superior. None of them is perfect at all. They use different variables in order to try to anticipate mortality and morbidity, anticipate the severity of the condition, to help stratify the patients, which patient is going to be admitted to the ward, which one needs to be admitted to high dependency unit, and what sort of analgesia is going to be followed. To be perfectly honest, to my own understanding, your clinical judgment outweighs those scoring system. And the only reason that it's beneficial to have this scoring system in place is to have some sort of auditing tool. We collect data all the time. And if you say that, okay, I received those number of rib fracture patients with that sort of severity, and we did this sort of management and the outcomes were such and such, this will help you to know where are you standing in the care of that group of patients, rather than randomly managing them and not knowing whether what you're doing is effective enough or not. All of these scoring systems invariably incorporate the age, because age is a very important factor in the mortality, morbidity, and outcome of that group of patients, and also the number of fractured ribs as well. There are a number of them. Most commonly, and one of the simplest, is the rib fracture score, like we're going to see in the next slide. Another one is the chest trauma score, and the rib score, which is mainly a radiologic score that's done by our radiology colleagues, and again can delineate the severity of the condition of rib fracture. In terms of the rib fracture score, you count the number of breaks in the single rib, so whether it's single or multiple, and then you count the sides, whether it's unilateral or bilateral, and use a factor to reflect the age. And in most institutes, if the patient's scoring 7 or more, those patients have to be flagged to the acute pain team to keep them on their radar all through the care of those patients in hospital, in order to see whether they need escalation with the plan of analgesia or escalation with care or not. And the acute pain team is always situated in a good position as gatekeeper for that group of patients to monitor them and look after their care, unless they present in a more severe trauma and from the outset they have been intubated and admitted to the ICU. Unfortunately, this score is not good enough when it comes to the respiratory morbidity and mortality, and hence it's not a perfect single predictor outcome score, and you need multiple factors in order to be able to judge the outcome of that group of patients. Another one that we talked about is the chest trauma score. Again, it uses a number of variables, including the age, the number of ribs that have been fractured, and the pulmonary contusion that will be diagnosed by our radiology colleagues. And it adds extra points, actually, if there is bilaterality in the fracture of those ribs. And it's been designed essentially to predict the first 24-hour morbidity and mortality of that group of patients. Talking about the scoring system, I think the most important take-home message is, in your practice, in your hospital, try to design some tool. You're not going to invent the bicycle. There are many tools online and available from different trauma centers in Europe and in North America or Australia and New Zealand. Pick up one and use it as a tool just to stratify your patients and see what sort of patients you receive to your hospital and what sort of management you do to those patients, and whether it's enough or not. One of the other tools that's widely used here in UK has been developed after a multi-centric study called the Study Evaluating the Impact of a Prognostic Model for Management of Blunt Chest Wall Trauma Patients, simply STUMBLE. STUMBLE, actually, English word, like stumbling in your movement. And it used a number of variables, including age, including the respiratory comorbidities, whether the patients are anticoagulants or not, and that's not an uncommon encounter, especially in elderly patients who present with atrial fibrillation and they are on anticoagulation for their atrial fibrillation, and whether they have underlying chronic lung disease or not, and how many ribs have been fractured. It's a very useful piece of tool. It can delineate your patients according to severity into mild, moderate, and severe, and helps the management of those patients and helps creating care pathways, like I'm going to show you in the next few slides. One quoted from University Hospital of Plymouth, which is leading in England in terms of dealing with rib fracture patients and managing them, which you can easily adopt in your institute in order to look after that group of patients. And that sort of tool is actually good as a predictor of mortality and morbidity of that group of patients. Now that we've talked about how patients present in terms of how they fracture their ribs, how you're going to assess them and diagnose their condition and deal with them initially when they came, now we come to the very important reason or essence from this lecture tonight, which is actually how you're going to treat those patients. Evidence tells us that it's not a one-man show treatment. It needs to be multidisciplinary, and by saying that, from the outset, you involve the emergency department. Invariably, you will involve the critical care or the outreach team in the care of those patients in order to keep them on their radar in case they need any escalation at any stage. As an anesthetist / pain management specialist, including the pain management specialist nurses, you have to be involved in the care of those patients because you have the knowledge and the skills, like what we're gonna discuss later, in how to offer them analgesia to help that group of patients. Physiotherapy, they are in the center of the care of those patients, and they are looked after by our physiotherapy colleagues who help them with orientation and practice of deep breathing, coughing exercises in order to help them with speeding up their recovery. And ideally, this management should be within a written protocol that everyone follows, and they trigger certain pathways as soon as they hit the emergency department in their hospital. And that's not an impossible thing to develop. Actually, you can develop this sort of protocol, and by practicing and auditing and reflecting on the quality of your practice, you can improve the quality of care of that group of patients. Your management will focus around certain points, as you would expect, definitely ventilation and oxygenation. They might need variable types of oxygen supplement, starting from the simple face mask or nasal cannulae, up to the use of high flow nasal cannulae or non-invasive ventilation. And sometimes that the condition is really severe or due to other injuries, invariably they might need to be intubated and ventilated on the critical care unit. So that's one of the areas where you're going to manage those patients. One of the cornerstones which brings about our role as anesthetists and pain specialists is the management of analgesia for those patients. By all means, it has to be multimodal. You can't actually depend on just single mode of analgesia. You're going to use the simple analgesia. You're going to follow the WHO ladder of analgesia, which, as all of you know, was developed initially for cancer patients, but it's been extrapolated to all acute painful conditions. So you're going to use simple analgesia, including non-steroidal if there are no contraindications. You're going to use opiates up to using PCA opiates, but you have to be careful when you're dealing with elderly patients. And you're going to use as well adjuvants, and one of the commonest to be used in that group of patients, not that it's supported by strong evidence, but you will find most of trauma centers using them, gabapentinoids like pregabalin and gabapentin. And again, you have to be careful when you're using them in that group of patients. And most importantly, and like you can see, I put many pluses beside it, using regional techniques as we're going to elaborate later, which actually are the golden standard for the management of analgesia for that group of patients. Like we said, physiotherapy, you will need their help. So make sure that they are involved as early as possible in the care of that group of patients. And you have to consider escalation of care from ward level of care to level 2 or level 3, according to what's needed for those patients. And all of you would appreciate how tight and difficult is it to get a high dependency or ICU bed during the COVID circumstances, when most of hospitals, at least here in UK, while I'm talking to you, are being overwhelmed by COVID patients. Like we said, the elderly patients are a very important group. You have to be careful. You will need to make a lot of decisions about them, so you'd better manage them appropriately from the outset in order not to end up in a difficult situation where you need to make a decision about whether you're going to escalate or not. And ideally, you have to involve the orthogeriatricians in the care of that group of patients, because they are best situated to deal with them in case they have cognitive impairment or in case they have any element of delirium or Alzheimer's disease, and they will be able to deal with these changes because they are experts in that area. And last but not least, consideration by our orthopedic or thoracic surgery colleagues, whether those patients are amenable for fixing their fractures or not. And we're going to touch base on that at the end of the lecture. Like I said, developing a protocol is really important. I quoted this protocol from University Hospital of Plymouth, and like I said, they are leading in the management of that group of patients. They had very important role in the Istanbul study and the score. And like you can see here, it's color-coded pathway, green, amber, and red, and it delineates the severity of patients presenting with rib fractures. It's multidisciplinary in essence, like we said, it's not a one-man show. And then according to the severity, you involve other teams and use different modes of analgesia, including, most importantly, the use of regional techniques for the care of those patients. So make sure that in your department, you discuss it with your colleagues, you discuss it with your seniors, and you try to develop some sort of pathway for the care of those patients. Audit it all the time and reflect on your practice to see where are you standing in terms of the care of those patients. I'm not going to mention the specific analgesia that they mentioned here in their protocols, especially opiates, because it's different from one place to another and different from one country to another. But you have to be sensible with what you use up to using PCA. And like we said, think always when you need to step in with a regional anesthetic technique in order to be able to deal with those patients and improve their care. Now we come to the juicy part of the lecture, which is talking about regional anesthetic techniques. And we can actually break them into two major types: old school types of analgesia, including thoracic epidural and paravertebral block, and the newer techniques, the fascial plain block techniques using ultrasound and using catheters that are every few years, you will find a new one, sometimes every few months actually, you will find a new one emerging and gaining turf in the care of that group of patients, or even in the care of thoracic surgery when it's unilateral in thoracotomy. The exact details of those topics are actually beyond the scope of this lecture because they are a lecture on their own, but we'll try to touch base quickly about what are the commonest ones used in practice here in UK, and I think might be in different countries as well, and what are the pros and cons of each of them. Thoracic epidural, of course, it sits at the top as a golden, I won't say standard, as in terms of highest quality analgesia that can be offered to that group of patients, especially if the patients are presenting with bilateral rib fractures. But unfortunately, it does come with a number of caveats. So sometimes it's difficult to perform if you're not used to using them, especially nowadays for laparotomy or for thoracotomy. Clinicians and surgeons are moving away from using thoracic epidurals. Those patients are trauma patients. Bear in mind that they might come with some sort of spinal fracture or contusion of the spinal cord, and you don't want to go near them with your needle if this problem is in place until they are cleared from the neurosurgical side. Like we said, elderly patients invariably come in with anticoagulation on board. You won't be able to stick your needle if that's the condition. You're going to compromise the hemodynamics of those patients if you're going to run a thoracic epidural infusion, and invariably you'll find yourself needing arterial line, central line, vasopressors, most commonly noradrenaline, and needing to admit them in a monitored area. And sometimes, like I said, I'm keeping repeating myself, but in the COVID era, that's not something easily accessible for that group of patients. So you're going to complicate their care because you're only offering them thoracic epidural. The other modality of analgesia that again falls under the category of the old school is the use of ultrasound-guided paravertebral block and catheter. The risk of causing hemodynamic compromise is less in that group of patients because there is less risk of causing sympathetic blockade. It can be offered unilaterally or bilaterally. It doesn't have the impact on mobility that you're going to have with thoracic epidural. Most wards are trained and are happy to look after that group of patients. But again, it's not that easy to perform. It needs learning curve to develop. So you need your center to be doing a good number of them for you to be competent in offering those paravertebral blocks and having trained teams to look after those group of patients. And if you go back to the anatomy of the paravertebral space, you're very close to the pleura. So you run the risk of injuring the pleura if you're not well trained. Having said that, most of those patients might have pneumothorax and chest drain in place, but that doesn't mean under any circumstances that you will be reckless and go with your needle inside and then cause injury to those patients. So you have to be careful and you have to learn them well. Then came the newer blocks that actually revolutionized the care of that group of patients. And by name, I'm talking here about the erector spinae plain block and catheter, and the serratus anterior plain block and catheter. In my current hospital, we do paravertebral blocks. In one of my previous hospitals, where I was trained in pain medicine, we do more of paravertebral, erectorospiny, and serratus. And the beauty of the fascial plain blocks actually is the margin of safety that they have, the easiness of learning them. I won't be exaggerating if I say you can actually learn them. If you're good at regional ultrasound guided regional blocks and needling, you can actually learn them off YouTube if you want. You don't need to watch them many times in order to feel confident to hold the probe and hold the needle and start doing them. They are safe. Evidence tells us that they are safe in anticoagulated patients to perform, because the worst case scenario, if the patient develops a hematoma, it will be in a fascial plane, it will be contained and won't need too much complications like cord compression, for instance, if we are talking about thoracic epidural. They are equally effective, but the downside of them, because they are relatively new, so we don't have robust randomized controlled trials comparing them to the old school techniques, and we don't have studies in place evaluating their mortality benefit. Similar thing, by the way, applies to thoracic epidural. So we said it's the golden standard in terms of analgesia, but it doesn't cause much difference in mortality of those patients. But those erectorospiny and serratus anterior have revolutionized the care of those patients. And I would urge all the audience listening to me tonight to try to endeavor and persevere learning those techniques in order to improve the care of that group of patients. And even if you're dealing with unilateral thoracotomy or breast surgery with serratus anterior, these are very valuable newer block techniques that are gaining, like I said, turf in different areas of analgesia and anesthesia. Sorry that I didn't put a video on because of copyrights issues. But here, what you can see, those photos are taken from the internet, from Google, actually. Like you can see here on the right-hand side, you can see the erectorospiny muscles. And what you do, actually, you go in plane with a high-resolution probe, and you start scanning from lateral, where you find the rounded shadow of the ribs, and you scan slowly, immediately, until the shadow that you can see is squared off, telling you that now you are standing on the transverse process of the vertebrae. You choose a level that lies in between the fractures, and you're expecting spread above and below where you're doing your block. You go in plane with an in plane technique from the top or the bottom, and what you're aiming for, actually, you have an end point. What you're aiming for is the transverse process under the erectorospiny muscle, in the plane between the transverse process and the erectorospiny muscle, and you inject your local anesthetic. It's a fascial plane block. It's a volume block. You need big volume, up to 40 mils of ropivacaine. We use ropivacaine 0.75%, or you can use levobupivacaine if that's what you use in your practice, and you use big volume. You see this space opening in front of you, you hydrodissect it with your local anesthetic, and then you spread a catheter in this place. Just one of the tips that some of the clinicians do sometimes, they do the hydrodissection by saline, so that if the catheter gets displaced, they don't get initial analgesia by the local they injected. And then when they run the infusion by the catheter, they get called a few hours later telling them that the patient is in terrible pain. And then they go confused. Is it a problem with the catheter? Is it a problem with the block? So they hydrodissect with saline. And when the catheter is in, this is when they put their local anesthetic to be sure that the catheter was in the right place and the local anesthetic went through, causing the analgesic effect, and then they run infusion. Similar thing, I think, applies to most of fascial plane blocks, including fascia iliaca for neck of femur fracture, and including serratus anterior and different sorts of fascial plane blocks. Serratus anterior is the other one. I forgot to say that the strongest indication for erectorospiny is if you're dealing with posterolateral fracture. So the ribs got broken actually at different areas. So if you're dealing with a posterolateral fracture, definitely paravertebral and thoracic epidural will cover that. But if you're going for a fascial plane block, so erectorospiny is excellent for posterolateral fractures. While if you're talking about serratus anterior, you're talking more about an anterolateral fracture that you want to cover. Like you can see from this picture, you go into the anterior axillary line at the level of the fifth rib. Actually, this area is very famous and very popular for different sorts of block. So coming from underneath the clavicle, you can do the infraclavicular brachial plexus block for various indications. That's out of the scope of our lecture today. Going down to your second rib, you can do what they call PIX1 block between pectoralis major and pectoralis minor, where we use it for breast surgery or insertion of pacemaker, etc. And going down to the third rib, you can do PIX2 block. That some people actually say that PIX2 is the same as serratus anterior. Now we are focusing on serratus anterior. You see the ribs, and then it was described by Blanco and colleagues. You can either deposit your local anesthetic, it's again volume fascial plane block, either deep to the serratus anterior. So you go down to the ribs and you put your local anesthetic in, or superficial to the serratus anterior between the latissimus dorsi and the serratus anterior, like this picture shows on the right-hand side of the slide. You put local anesthetic, and then you put your catheter and you run infusion afterwards. And in practice, what I find personally in practice is if you combine this with PCA and simple analgesia, you get the best effect. And if you go and follow up your patients, you'll find that their use of opiates via the PCA is minimal compared to just PCA without one of those fascial plane blocks. Like I said, they are easy to perform. Actually, some of the anesthetic practitioners, and that's a job in North America and to smaller extent here in England. Some of them are actually trained to do regional blocks. They are very good at needling and the use of ultrasound, and you can just send them to evaluate those patients and do blocks for them, and they are happy to do them. And this tells you how easy those blocks are could be done and how safe they are to trust a non-physician to go and do those blocks for patients. Now comes another modality of management, and that's actually falls in the hands of our surgical colleagues, which is the use of surgical fixation. Here in the UK, the practice is really very, very variable. It could be done by orthopedic surgeons, it could be done by thoracic surgeons. It's variable in the timing of doing those surgical fixations, and variable in the indication. But the strongest evidence-based indication that's recommended by NICE, which develops most of the guidelines that we use in practice here in the UK, is having someone with flail segment that's needing mechanical ventilation. And the reason behind that, you need those patients to have effective ventilation when you fix the flail segment, and then you liberate them of mechanical ventilation. Surgical fixation was very fashionable at a certain point. Unfortunately, it went out of fashion at certain stage with all the improvements in the critical care that could be offered to those patients, including weaning for mechanical ventilation, the non-invasive ventilation techniques, etc. But then it regained popularity again because it helps weaning those patients from mechanical ventilation. Other hospitals might follow other indications for rib fixation surgically, and as you can appreciate from this slide, they all revolve around the severity, the number of fractures, the need of mechanical ventilation, the development of respiratory morbidity, which would make them think about fixing those ribs. Orthopedic surgeons in our hospital get involved in that as early as possible. You do 3D reconstruction of your CT scan in order to be able to judge whether those ribs are amenable for fixation or not, and then you take it from there. Some contraindications, yes, if you have other conditions that preclude putting the patients at risk of fixation. You're dealing with a trauma patient. They might have traumatic brain injury. They might have very tight brain in terms of ICP and cerebral perfusion, and you won't put them at risk of surgery, which invariably needs one lung ventilation and compromise of oxygenation and ventilation, which might have risk on their cerebral perfusion pressure, especially if you're not anticipating to wean and extubate them any soon, and they are well analgesed and well sedated in ICU, so you can carry on looking after them without fixation until everything improves. And by that time, pain secondary to rib fractures won't be much of an issue in order to wean and extubate them. The other thing, as you would expect, you're putting metal work in place. So if there is infection and empyema, you would try to abstain from doing surgical fixation for them in order not to complicate the problem. But like I said, this falls in the hands of our surgical colleagues. It's not our decision, but it's one of the things. If you are in the ICU, you're struggling with the ventilation of your patients, you'd like to wean them, and you think that surgical approach might be helpful, get hold of your colleagues if they are trained in doing rib fixation. Then last, before summarizing my talk tonight, governance. It's very important when you have certain group of patients where you think that you can improve the quality of care that you offer them, to have a governance system in place. One of the first things that you will have to do is to collect data. You have to see the number of rib fractures that come to you every quarter of the year, what sort of severity those patients presented with, things like age group, what sort of management, whether all the teams that are supposed to look after those patients replied to the request of reviewing them on a timely fashion, and what were their action and documentation in the notes of the patient, and always reflect on that in order to improve the quality of care of those patients. Ideally, you should protocolize the care of those patients by adopting one of the pathways that are available from different trauma centers, and put these in place. Train your teams and different members of the multidisciplinary team on following those protocols for the care of those patients, and always audit and reflect what you're doing for that very important group of patients. To summarize my talk tonight, like we said, rib fracture is an important area of practice, and we are in the center of the care of those patients as anesthetists/pain specialists, because it carries higher risk of morbidity and mortality for that group of patients. Even with optimal management from the outset, those patients down the line will not regain their function straight ahead. They will need rehabilitation, and they might go on and develop a chronic pain condition, and then I will see them in my clinic. And hence, proper management of them is paramount, and it should be through a multidisciplinary team, like we explained during the lecture. Thank you very much for your listening, and I'm happy to receive any questions. Thank you, Walid.
Perfect. Lovely lecture, Dr. Mahmoud, as usual. And here we have two questions. Then I have one or two myself, but I will start with our guests here. So the first question from Muhammad Muqbil. What is the role of ultrasound in assessment of rib fractures?
It does have a role, not directly in assessing the fractures themselves, because as you would know, when you use ultrasound, they get reflected from bone. So you won't be able to assess them. But you can assess the excursion of the diaphragm. You can assess if they have pneumothorax or hemothorax, and make your decision based on that. If your patient's quickly deteriorating and you're not sure what's happening exactly, and you don't have time to image them. But like I said, here in UK, almost all trauma patients will have access to trauma CT in timely fashion, and this gets audited. But if the patient's too unstable to be moved to the radiology suite, you can do, if you're trained, I'm not trained in fast scan, but I can do chest ultrasound. If you're trained in fast scan, do it, including the lungs, to see if there is any big amount of hemothorax or pneumothorax, which will definitely make a huge difference if in your management. You might need to stick thoracostomies bilaterally, or even in extremes, if your patient develops cardiac arrest, going for clamshell, which actually was a juicy topic that I was thinking, shall I talk about it in blunt and penetrating trauma or not? But I thought it's heroic act. We do it in A&E, not me personally. I'm part of the team that might end up doing that. And one of the patients that we had to do resuscitated thoracotomy, I transfused him in total 62 units of blood, half of that of fresh frozen plasma, half of that of platelets, and half of that of cryo. And as you would expect, the patient died. So it's a heroic act, but the outcome is very poor. So this is why I thought rib fracture is something that gives favorable outcome and it can make a difference. But in answer to your question, this is where you're going to use ultrasound when you're looking after rib fracture patients.
Okay, Dr. Mahmoud, if you don't mind, we'll start the poll to assess this picture and document the attendance while we're going ahead with the questions. I may add to that, if you agree with me, ultrasound can be used to assess for, as you mentioned, the pneumothorax or the sequence of the trauma, lung contusions, hemothorax, pneumothorax, cardiac contusions with echo, aortic dissection. There's a lot of use in EFAST. But what I'm concerned with, if one is doing ultrasound lung with a patient with multiple rib fractures, consider the patient pain management first, if you can, because keeping pressing on the patient chest is something which is very painful and may lead to more and more tachycardia and may lead to consequences that we are all not in need of in that scenario. So, yeah, and the last thing I would recommend against is everyone is coming with the ultrasound and examining the patient at different instance. So like if you examine the patient and you're confident enough, you're the most senior person using the ultrasound in this scenario, that's well and good, document not to repeat the exam again. So again, for this patient with multiple fracture ribs or fracture sternum, he's in severe agony and repeating an exam once and after or twice will be something the patient himself is not pleasant with. So
you don't want to put your patient in severe agony. Actually, that's inhuman. So you have to be sensible about what you're doing and make sure that it's actually put yourself in the shoes of the patient really, and make sure that it's an examination that's gonna have some sort of outcome, or you're gonna make a decision, not just as a matter of practice.
Okay, Dr. Mahmoud. So what about intercostal nerve block in pain management rather than retrospinal block or epidural or whatever? So
that's a very important question, and I was anticipating this question. Intercostal blocks have been through history like very important modality for the management of that group of patients, but just bear in mind that you will need to do multiple levels. The absorption from the neurovascular bundle is really high. So if you use big volume of local anesthetic, you're gonna put this patient at risk of local anesthetic toxicity. It's very difficult to put a catheter, so most probably you will need to go back again and again and again to do multiple injections, which practically is really difficult and even further increases the risk of local anesthetic toxicity. So theoretically, the answer is yes, they do have a place, but in reality, it's not practical.
Perfect. I think we answered this question now. So the next one is, can we start gabapentin or pregabalin in the pre and post-operative period to decrease the incidence of chronic pain? So is there any rule for chronic pain medications in the acute pain stage?
You will find gabapentinoids invariably used in that context in acute pain, thinking that we're gonna minimize the risk of developing chronic pain. Unfortunately, I'll disappoint you. The evidence behind that is really slim. Actually, a lot of people have a lot of reservation around gabapentinoids after they were very popular at certain stage. They are controlled drugs now in UK, so they are dealt with as controlled drugs. Pregabalin actually gets traded in prisons, and we see a lot of patients coming from prison with painful conditions, and we look after them, and we try to avoid prescribing pregabalin for them. The number need to treat is higher than you would anticipate. So I know they are in different sorts of protocols for the management of acute pain, but the rule in preventing chronic pain is really not proven by evidence, unfortunately. Sorry to say that.
Perfect. So I think we are now heading towards the end of this night, wonderful night again. Thanks for everyone attended tonight. We are approaching 200 attendees almost all the time. So thanks for your persistence. And thanks for our guest speakers tonight, Dr. Ahmed Fouad Madi and Dr. Mahmoud Al-Khulani. See you next week with 2 new topics. And please don't forget, if you registered already in Critical Care Ultrasound Updates Conference and you didn't get an email yet, please straight away email me, because all the emails are already gone. contact@savinglivesacademy.com. And if you don't register, please go and register now. It's the first time to happen. 14 different speakers, 7 different countries, 21 essential topics on updates of critical care ultrasound. These people never gathered under one roof, so that's your time and chance to see and listen and watch them. Thanks very much again, Dr. Mahmoud, and see you next week.
Thank you.